Then today we will have two honored international speakers. To the main focus of this course, the discussion about what can laryngeal EMG give us on additional information. Can we conduct the prognosis from EMG of recurrent laryngeal nerve paralysis? And a lot of members of this course in the years before told us that they would like to have more basic information about EMG and how the signal is produced in the muscle structure. Therefore, we are really grateful that Wilhelm Schulte-Mattler, the most famous German neurologist on the field of EMG, will give us an introduction on EMG. And in the later part of this course, Clark Rosen, one of the famous US laryngologists, will share his ideas with us about quantitative EMG and more advanced EMG. So this is the program for today. Here we are located in the center of Germany. The cities of Jena and Gera are nearby, half an hour by highway. Why we do these courses? We came from laryngotracheal stenosis, laser surgery, thyroplastic surgery, and then we found that the function of the larynx can only be restored if you learn more about neurolaryngology. We are the founders of a scientific project concerning laryngeal pacing. We established in our departments laryngeal EMG, and we perform a lot of laryngologic procedures and surgeries, for instance, planar innervation, augmentation, thyroplasties, and we organize since 2011 neurolaryngology courses for experts and for beginners. So these are some of our recent publications. You see, we are working on different topics about laryngeal EMG, about synkinesis, and on laryngological aspects. This is the history of our workshops. You see, we had a lot of famous persons on the field of laryngology as guests in this course. And this year, we are proud to have Walter Schulte-Mattler and Mark Rosen as guests. In 2019, we had development of our course that delegates from 11 nations joined our course 2020, and this year we have a reduced course because of the travel restrictions and the corona pandemic. So we are hopefully looking forward to the next year to have this course again as an international course with real participants. So this is the schedule for this afternoon. After my words, we will start with the presentation and we will end up around 6 p.m. and you have between 4 and 4:15 a bio break. And then we try to get the line to San Francisco. So this is the program for today, and the other information for tomorrow I will give later on. So now I would like to introduce our first speaker, Professor Wilhelm Schulte-Mattler from Regensburg. He is one of the most experienced neurophysiologists in the field of neurology. He has written a standard textbook on EMG in the German-speaking area. This is the most noticed book on this field, and he's really didactic, and I think he can give us really an introduction what goes on in the muscle fibers if we stick a needle in, and what we see on the screen or what we hear with our ears during EMG. So, Professor Schulte-Mattler, welcome to you, and I would like to give you the mic.
Hi, thanks for the introduction, and thanks for the opportunity to join this meeting. It definitely should be very interesting, not also for ENT, but also for neurologists. Should be interesting. So, as I have the mic, we're early. Is it okay if we start right now for the sake of time, or shall we wait until 1 p.m.?
I think we can start slowly.
Slowly. Well, then hello to the audience. I hope this works. Can you see the first slide now?
Yes.
As intended, I'll try to give you a brief introduction into electromyography and what it has to do with pathophysiology of paralyzed vocal folds, but not only of vocal folds. Actually, muscle physiology or neurophysiology of neuromuscular disorders, in this field, it doesn't really make sense to differentiate between cranial muscles and muscles of the body. The main difference between those cranial muscles and extremity muscles, limb muscles, is their size. And of course, the ENT fraction, the ENT department, is very well able to handle with these, to deal with these small muscles manually. And indeed, this is the main difference. So I will focus on pathophysiology of muscle and nerve and what EMG can do for us. And keep in mind, this is the key to electromyography. Always keep in mind, please, that all of our muscles are organized in motor units. The motor unit, this is the alpha motor neuron or the nuclear neuron in the brainstem. So there are those neurons. Here's just one as an example. And those neurons are wired or connected to the muscle via one fiber, one axon. And this axon, like the roots of a tree, for instance, splits into subdivisions and is connected to a number of muscle fibers. This is important to keep in mind, that one axon drives many muscle fibers. In limb muscles, it's from 100 to 500, with some exceptions. And in the cranial muscles, it's less muscle fibers per motor unit. So it may be as low as 10 in extraocular muscles, 10 to 20, or some 20 to 100 in most of the other cranial muscles. Again, this is just a matter of quantity. The difference between those cranial muscles and the limb muscles is not of crucial importance. What is meaningful is, or what is important, that this one neuron is wired to some muscle fibers, and that there are many neurons that are not in display in this slide here. This is just one example. And we record in the left part of the image, you see our needle electrode. We insert a needle into the muscle, and the needle will record the signal of some of those muscle fibers that are close to the tip of the needle. And what we record is displayed here, is the so-called action potential. And one action potential follows one discharge or one action potential of a motor unit. It travels around here and generates a muscle action potential that can be taken up by the recording electrode. That's what we do when we record electromyograms in cranial muscles as well as in limb muscles. And the goal of electromyography is to differentiate the various types of grades of nerve lesions or muscular disorders. We won't deal with myopathies here, so we just talk about the various grades of nerve lesions. And one method to differentiate or to name those lesions is displayed here. The normal nerve is shown in the upper line, transmits the electric impulses. We call it saltatorily. That means that the electrical voltage travels, it jumps from one node of Ranvier to the next one with a certain speed. And the speed at which it's done is determined by the distance between those Ranvier nodes. And if the myelin sheath is doing well, we have some conduction velocity as expressed in meters per second that ranges from some 50 to 60 meters per second. The conduction velocity can easily be determined in peripheral nerves, such as in the median nerve of the arm, for instance, but it cannot be determined in cranial nerves, as the measurement of the conduction velocity, which is done by the method called ElectroMyoGraphy, requires that we stimulate a nerve electrically at 2 different sites. And we can't do this in the cranial nerves, with the exception of the facial nerve, for instance, but the facial nerve can only be stimulated at 1 site, not at 2 different sites. So we're unable to determine this conduction velocity. It is meaningful to determine that conduction velocity to detect this kind of nerve lesion called demyelination. Demyelination happens upon repair of the myelin sheath. So if myelin sheaths get compressed and the myelin sheath is compromised here, the recovery process usually leaves the myelin sheath in a way compromised. And where the myelin sheath had been compromised, the conduction velocity is lower because the distance between those Ranvier rings is reduced. So demyelinative disorders can be detected by conduction velocity measurements. So it is not easy to detect the demyelination in cranial nerves. In most of these nerves, it's impossible. It is not that meaningful, as demyelination usually occurs with inflammatory disorders or with compressive disorders locally. Well, another kind of nerve lesion is called neuropraxia. Neuropraxia is acute, normally caused by an acute lesion of the myelin sheath, and it blocks the conduction of the nerve. Here, in this instance, conduction velocity is reduced, conduction is slow, but conduction does not take place in this kind of nerve lesion. So what is the clinical correlate of this? This is, if it's a motor nerve, the clinical correlate is weakness or paralysis. The electrical properties of this nerve are intact, with the exception of this segment here. Cause of neuropraxia usually is compression or ischemia. A more severe kind of nerve lesion is axonotmesis. That means the axon, the nerve fiber itself, is structurally damaged. The result is similar to what happens in neuropraxia, namely, the conduction does not take place. So the clinical correlate of this condition is the same as with neuropraxia. In both instances, the conduction does not take place. The result is weakness or paralysis. Now, please keep in mind that one nerve is not only one fiber. This image here shows what happens to one fiber. In a nerve, both conditions, neuropraxia and axonotmesis, may well coexist. So some of the fibers may be damaged, axonotmesis. Some of the fibers may be neuropraxic. So if all fibers are hit by the same disorder, but only some are neuropraxic and some are axonotmetic, the recovery is determined by the number of neuropraxic fibers, as the recovery in neuropraxia is usually quick and complete. So there will be no scar, nothing, no remainder with this fiber. The recovery from axonotmesis is different. It takes place very slowly. The axon must grow from this site towards its distal part. And this takes place usually at a speed of 1 millimeter per day. So the recovery process is quite different between these two conditions. And therefore, it's of crucial importance, to differentiate these conditions to determine what has to be done to provide recovery to the patient, not only to the nerve, but to the patient. So remember, neuropraxia, axonotmesis, we must know what percentage of axon, or we must guess what percentage of axon is affected by one or the other type of disease if we have a patient with some kind of weakness. Sorry, a busy slide. We'll repeat that a couple of times. It is not, you need not to learn this by heart. It just the idea is to show you that the different kinds of nerve lesions here, neuropraxia, axonotmesis, and neurotmesis, I will show you in a second what this is, have some consequences as determined by electromyography or neurography or ultrasound. And there is a certain sequence, time, in which the phenomena occur. This is here are some times given this display that are important, as they are kind of milestones that are passed by a disorder or by recovery. We need to know what is partial axonotmesis or total axonotmesis or neurotmesis. What does it mean? I told you that their axonotmesis or neuropraxia is taken or is expressed per axon. If some of the axons are axonotmetic and some are not, we call this a partial axonotmesis. If all of the axons are damaged, we call it a total axonotmesis, logically. And we differentiate this from neurotmesis. This is a condition in which the whole nerve is damaged. Total axonotmesis says that the structure, the outer structure of the nerve macroscopically is intact. Neurotmesis means that you see macroscopically that the nerve is damaged. For instance, it may be dissected iatrogenically or by trauma. These conditions, it's of crucial importance also to differentiate these conditions, as a nerve that is neurotmetic will never regain any function without surgery. In these conditions here, it is more difficult to determine what is to be done, as the prognosis is different depending on the time and the severity of the lesion. And I'll show you some of the EMG findings that help determine what kind of lesion we find. And keep in mind that those changes in EMG, the pathologic findings, have a timely sequence. They do not all of these changes occur immediately upon a lesion, but it needs some time for those phenomena to develop. We'll go over this. This is a situation we have with our needle EMG. You see here a dissection of a muscle, and you see the needle, and this is redrawn from a microscopic picture. So the needle has some size, and what you see here is muscle fibers in a cross section. Those green fibers represent the muscle fibers belonging to one motor unit. You see they are scattered around in the muscle and not packed, not clustered. And you see that there's some space between those fibers on one hand. And you also see here two circles across the needle. The outer circle somehow represents, semi-quantitatively, the uptake area of the needle electrode. So those fibers within the outer circle contribute, or mainly contribute, to what is recorded electrically by the needle electrode and what is displayed on the screen of the EMG equipment. EMG is seeing, like an oscilloscope, what happens electrically in the muscle. The inner circle, semi-quantitatively, represents the uptake area for what we hear when doing EMG. Only few muscle fibers close to the needle tip contribute to what we can hear. So when we're doing EMG, we have a loudspeaker, and we have a screen, and they synchronously display or make audible what is in the muscle. And those fibers here contribute to what we hear, and many of the fibers of the motor unit, but not all of them, contribute to what we can see. And now, first phenomenon. Imagine this situation. The needle is in the muscle, and only this green fiber is discharging electrically. How can this be? Remember, those muscle fibers are connected to their anterior horn cell or motor neuron. And if the motor neuron discharges, the muscle fibers will discharge. And in a healthy muscle, this is the only way for a muscle fiber to discharge. The only condition that makes a muscle fiber discharge is when it gets a command by its anterior horn cell, or by its motor neuron. The motor neuron says, do motor fiber, do discharge, and it will. But if a motor neuron says discharge, or it does discharge, all of the muscle fibers of that motor unit get the same command and they discharge. So this particular situation of one muscle fiber discharging will never occur in a healthy muscle. And this is what makes these discharges of single muscle fibers a pathologic finding. And they are labeled pathologic spontaneous activity. Why is the name pathologic? Because it is the case. It truly is the case. If we find this, if we trap this situation in the muscle, we may be sure that there is some pathology with the muscle. It is not fully specific for any process, as neurogenic processes may generate or may cause pathologic spontaneous activity, and myopathies may do as well. In our context, we deal only with neuropathies, and pathologic spontaneous activity now shows that there is something wrong with the axon. Axonotmesis will cause pathologic spontaneous activity. Neuropraxia does not. So it's a way to differentiate or to learn whether axonotmesis has taken place or not. However, it is not as easy to determine that only one muscle fiber generates a signal. This is kind of typical signal we can record when doing EMG. This is a physiological motor unit potential, just to show you what we can measure. We can measure amplitude here from A to A. We can measure duration. We can count the phases, the components above and below the baseline, or we can count the turns, the turning points in the signal. All these measures can be done, measurements can be done, but none of these values differentiates whether this is one muscle fiber that is discharging or whether this is a motor unit. For instance, intuitively, you may guess that the measurement of the amplitude, if it's low, will show this is a single muscle fiber. And if the amplitude is high, we will guess that is a bundle of muscle fibers, that's a motor unit that is discharging. Unfortunately, the range of or the range of amplitudes of single fibers and the range of amplitudes of motor units overlap to such an extent that is virtually impossible to determine by amplitude measurement whether we have a muscle fiber discharging or a motor unit. And it's even worse. Here you see two signals. That is our original EMG recordings. This is 1 second in duration. This is 1 second in duration. Both signals are recorded without any voluntary effort of the individual studied. So the activity is spontaneous, as there is no voluntary effort. The question now is, which of these recordings represents pathologic spontaneous activity and which one is normal? Actually, one of these recordings was taken from my own biceps muscle, left biceps muscle, some 30 years ago. So since then, this muscle was pretty well working. So we may guess that this muscle was well at that time. The other recording is taken from a totally denervated hand from a person who had an ulnar dissection. So one muscle was totally denervated and the other muscle is, I feel, totally well. Which is the pathologic one? Well, we can try to interact. Is there any possibility to interact with the participants? So I'd like to learn what you will guess. Which registration is the pathologic one and which one is not?
We could ask the participants to go thumbs up for the upper line by reactions. So like this. This would be a vote for the upper line. Or you can unmute you. You're free to share your picture and your mic.
Keep in mind, there's exactly one solution. One is the pathologic one. There is a chat.
Chat is also fine. Yeah.
Up. One participant guessed up is the pathologic one.
So please all raise your hand if you think line 1 is the pathologic one. Kann ich mir den Daumen hoch machen?
Of reaction.
Ach so, Reaktion.
The upper one or the lower one. Keep in mind, this is original registration, and we need to make it to decide which one is the pathologic. In reality, we must decide whether we feel it's pathologic or not. Upper line is pathologic, upper pathologic. Many votes for the upper line. Anyone who will comment on why he or she considers the upper line pathologic. Well, we give a solution in a second. First, we dissect the image. Here, you can see enlarged visions of parts of these waveforms we displayed a second before. This one, you see the scale is changed. Now it's enlarged vision of one of those two waveforms. And potentials that look like this one here. They are small, low, and start with an initially deflection downward. Those potentials are usually called fibrillation potentials. It's a trap. It's a problem with this label, as if we call this a fibrillation potential, we wish to imply that we consider it pathologic. The use of the word fibrillation always implies we give it a pathologic meaning. And this looks like a fibrillation potential, very exactly. It resembles the fibrillation potentials, but it is not. It's from my biceps. Similarly, potentials that look this way, that start with the downward deflections, they are sharp and have some after discharge here. Those potentials are called positive sharp waves, and they're considered pathologic too. So if you use the word pathologic sharp waves or positive sharp waves, positive is downward deflection in electromyography. If you use this term, you consider this pathologic. Positive sharp waves are always pathologic. Unfortunately, again, this one just resembles a positive sharp wave. It's from my biceps. It exactly looks like a positive sharp wave, but it is not. This one here at the right-hand side, it starts with an initially upward negative deflection. Potentials of that kind are called benign fibrillations or end plate potentials or end plate spikes. They are considered normal, and you usually find them as the name says, in the end plate region of a muscle. And this normal potential is recorded from the totally denervated muscle. So the message here is, it is definitely impossible just from one potential, from any of its measures or shape or so, get a solution or get a clue to whether it's pathologic or not. Here's a solution. This is another registration, another recording, 1 second of abundant pathologic spontaneous activity. And to illustrate what I mean is I have marked discharges of the same fiber as indicated by the same shape and size or so. And we measured the distance, the time interval between two subsequent discharges. And you see all these differences are quite similar, are very exactly the same. And this is the hallmark of pathologic spontaneous activity, that the interdischarge intervals of the same fibers are quite constant or change in a quite regular manner. You can display this graphically. Here's the interval at the milliseconds, and this is the first interval, the second, the third interval. And if you stretch the y-axis, you find a straight line. This is without the scale, and you can do this, the same procedure for all of the events here in this spontaneous activity, and you'll always find straight lines. They may climb a little bit, or rise or fall, but they are always straight. In contrast, this is voluntary activity, physiologic activity. You see up and down here with this kind of display. You see the discharge behavior is slightly irregular. So we have a first conclusion how to surely determine whether there is pathology in the EMG. That is, if you find a very regularly discharging event or potential, you may be sure it's pathologic. Regularity implies pathology. Irregularity implies usually that this is normal. The conclusion, when it's regular, then it's pathologic, holds very, very robustly. To determine whether it's regularly or not, you may measure the intervals. And you'll hear it is displayed that you never find the same interval another time. So the intervals are changing a little bit, but they're always a little bit different, which is not the case in pathologic spontaneous activity. So if it's regular, it's pathologic. And the solution, you were right, it's the upper trace. For instance, this one here, this is a positive sharp wave, and it occurs here and here and here and here. And if you measure the interval distance, you'll find that these intervals are exactly the same. We can display this in a wall with a beamer, overhead beamer, and take a measure, do the measurements, and you for millimeter per millimeter, it's absolutely exact. All of the events here in this waveform occur regularly, so it's pathologic. And this registration, well, it was a little bit painful for me at that time. It's from my end plate region. And the potentials resemble fibrillations. This is a common beginner's mistake, to record from the end plate region of a muscle and mistake this here for pathologic spontaneous activity. It's spontaneous, but it's not pathologic. It's strictly irregular, and thus it's not pathologic. Okay, when it's pathologic, when it's regularly, it's pathologic. And funny, you can determine the regularity by interval measurements, but you have an instrument built in your head. And this is, I think it's maybe your profession, namely our ear or our auditory system is very well capable of determining the regularity of these discharges. With only a little training, you can determine this just by listening to the regularity, to the firing pattern, and you can decide whether it's pathologic or not. A little training is required, but it is not too difficult. And as I said, your ears or your auditory system is very well equipped to be trained this way. When does this pathologic spontaneous activity occur, and in which condition? Pathologic spontaneous activity needs some time after a lesion to develop. It's 10 to 14 days until the first pathologic spontaneous activity occurs. You see here, after 2 weeks, you find it. PSA is pathologic spontaneous activity. The other things we go over later. And you see it occurs from the third week, from after 2 weeks. And this is very important. After a severe lesion, it may persist even after recovery. There may remain some muscle fibers ascending pathologic spontaneous activity as long as more than 50 years after lesion. So we probably can say for the whole life. So it's another common mistake to take pathologic spontaneous activity as evidence for a new lesion. It may persist after years after the lesion. The intensity lowers, so the amount of pathological spontaneous activity will be reduced over time, but it may well persist. So pathologic spontaneous activity is pathologic. It occurs after 2 weeks after an axonal lesion. Neuropraxia never causes pathologic spontaneous activity. Of course, a mixture, partial axonal mesis, maybe neuropraxia plus axonal mesis will cause it. And it takes 2 weeks. And this is the reason why in many textbooks you will read, do electromyography not before 2 weeks after lesion. We will learn that this is wrong, but it holds true for pathologic spontaneous activity. This activity needs 2 weeks to develop. We have another issue. Again, the same picture, the needle is in the muscle. We see the fibers of one motor unit discharging or not. And now we'll discuss the complexity of voluntary activity. Here I have colored a second motor unit. And you see that all these fibers are scattered, and the relationship between the motor units is stochastically with no regularity. However, our needle will take the activity not only of the green, but also of the red fibers, and we hear both the green and the red fibers. And we'll need to go over this slide for some time. What is happening here? The left-hand side is a healthy muscle. Again, I know this muscle very well. On the right-hand side, we see a muscle of a person who has a neural lesion. We'll see which kind of lesion. Top down, the first waveform here is, again, it's 1 second of duration. You see those spikes here, 1, 2, 3, I think it's 9 or 10 or so during this second. These are the action potentials of one motor unit. So this is a minimum effort. So the person who studied here, actually myself, was activating just one motor unit within the uptake area of the needle. This is the lowest degree of voluntary effort one can produce. If it's less than one motor unit, it's 0, so it's relaxation. And if one motor unit is innervated or recruited, usually we'll see minimum muscle contraction or not at all. This is very, very weak voluntary effort. And this motor unit discharges at about 10 per second. And from top down now, more and more force is generated by the muscle. So the second registration, the second recording here, is the same motor unit. And you see here, and later on here, a second motor unit is taking part in the contraction. We say it's being recruited. And here, third line, fourth line, more and more motor units contribute to that contraction. And this is how muscle force is controlled in the human body. That is the number of motor units taking part in a contraction. The more motor units are contracting, the higher the force output of the muscle is. And if you see here, you find the discharge rate of this is always the same motor unit here. The discharge rate is not very much increased. It's about 12. Here it was 9, 10, 12 per second. So with lower muscle effort or medium muscle effort, the force output of the muscle is controlled only by the number of motor units taking part in the contraction, and not so by the discharge frequency of the motor unit. This is very important. The fifth line here down below shows what we call an interference pattern. This is about maximum voluntary effort. So all motor units are taking part in the contraction. All motor units, what we say, are recruited. And we can see that we cannot see anything. We cannot differentiate the discharges of single motor units. It's just, as the name says, it's an interference of all these discharges. And what we cannot do here is determine any discharge rate of an individual motor unit. It's just many ups and downs, many turns. We call it a full interference pattern, as there's no interval where we can identify the baseline, and it was the case here. So full interference pattern and a crazy waveform without the possibility to identify single motor units. From recordings with special electrodes, we know that within this pattern here, that there are motor units that are discharging at higher discharge rates than just 10 per second. They discharge 20, 30, 40 per second in healthy muscles. But they are there, but we cannot see them. And this is how muscle force is increased when all motor units are recruited and the individual wants to produce more muscle force output. The individual motor units must discharge at a higher rate. So with high voluntary effort, muscle force is controlled not only by the number of motor units, but also by their discharge rate. Then it's a mixture. With lower force output, only the number of motor units determines the force output. This is the case in a healthy person. This condition is different. We see here the same as here. We see one motor unit. It seems to be small, but keep in mind that the scale is different. So it's exactly the same as in a healthy muscle. 10 per second, one motor unit, nothing special. Here we see the same case as in the healthy muscle. A second motor unit is recruited and it discharges at about 10 per second. From here, we find a difference from healthy to denervated muscle. We see that here we expect the third motor unit to recruit, as it was here the case. We expect this motor unit, but it's not there. Instead, the discharge rate of the remaining motor, of the two motor units, increases. It further increases line 4. We would expect the fourth motor unit to be recruited, but this is not the case, but instead the discharge rate increases, and it increases up to values of some 40 per second. And this is the case as in a healthy muscle with full voluntary effort. Maximum force output is intended by this individual. But we can now see the high frequency discharges of the motor units. And this is due to the fact that their motor units are missing. We can see the physiological phenomenon of a high discharge rate, and this is good that the motor unit can discharge at a high frequency. That shows that there is no central nervous system lesion. However, the pathology is that we can see we can see the high discharge rates. We can hear them, we can see them. I give you an impression of the sound. This is the characteristic sound of high frequency discharges of motor units of a denervated muscle. Again, it is quite easy to train, to learn to recognize this sound. And it is a very characteristic finding for denervated muscle. The maximum discharge rate of the motor unit has a very close correlation to the number of active motor units in that muscle. And the black dots here indicate patients with a neurogenic disorder. And you see that the discharge rate is correlated with the number of motor units in that muscle. And if the number of motor units is reduced, we found the discharge rate increased. We can also see that the discharge rates increase only if the reduction of motor units is quite significant. So a minimal lesion or a slight lesion of the muscle cannot be detected always by the finding of a high discharge rate. As we said, with spontaneous activity, if it's regular, it's pathologic. For the discharge rates, a similar rule. If it's too high, it's pathologic. There may well be normal pathologic cases with normal discharge rate, but if the discharge rate is found too high, it's pathologic. Here the warning in red. This picture here holds for limb muscles. In cranial muscles, is qualitatively it's similar, but discharge rates are higher. They may be up to 25 per second, such as in sternocleidomastoid. Facial muscles may reach 38 per second until they are pathologic. And it depends on the cranial nerve and on this, probably on the size of the muscle being studied. So here's one of the differences between cranial muscles and the limb muscles. Oops, go, vanish. Here, the same picture, but not with number of motor units, but with muscle force output. And you can see again, these black dots are denervated muscles, neurogenic muscles, and the open circles or open squares are myopathic or healthy muscles. And you can see with considerable weakness that the discharge rates increase. And here's the upper limit of normal for limb muscles. It's some 16, as a rule of thumb, you can say 20 per second holds for all limb muscles, but not for all cranial muscles. Some discharge rates or the limits of normal need to be established for cranial muscles. One meaningful point is, when does this phenomenon occur? And this is it does not depend on the time. So the phenomenon of increased discharge rates accompanies the lesion, the weakness, sorry. It can be found as early as 20 minutes after a traumatic nerve lesion, and it remains as long as the weakness remains. And if the recovery is full, usually the discharge rates return to normal. So there's no need to wait with the EMG, to wait for something to occur. If you want to determine discharge rates, you can do the EMG study immediately upon a lesion. We need to talk about what is called interference pattern, or reduced recruitment, or reduced interference pattern. This is a finding commonly described in many EMG findings, and it's some kind of old-fashioned in my mind. Here you have a picture you're already familiar with, the healthy muscle and the diseased muscle, but both recordings, all 4 recordings, are made, as you remember, at low voluntary effort. So the patient or myself were instructed only to do a very slight contraction, and you cannot see any difference in the discharge behavior. Now, the patient is instructed to generate more and more force output, and we find what we already are familiar with. We find that the discharge rates increase, but as the patient has lost most of his motor units, we can see the increase in discharge rate. Now, in the left picture, we skip these recordings here and think what is happening here when the patient does not provide full effort. And so this will be the limit. The patient will say, well, this is the utmost effort I can produce. Here, he could produce more effort, but he does not do so. What we find here, the patient says, well, it's my full effort, and we find a so-called reduced interference pattern. We expect a pattern of that kind, but it is distinct. The density of these spikes is not reached. So this is called a reduced interference pattern. It is similar as here. There are still parts of the baseline recognizable, as it is the case in here with this patient, but the difference is fundamental. This is a peripheral nerve lesion, and this is lack of voluntary effort. Lack of voluntary effort may be due to some incorporation, non-cooperation of the patient, but it is characteristic for all kinds of central nervous system lesions. So a stroke, multiple sclerosis, brain tumor, they all, if they cause weakness, they will all cause this kind of reduced interference pattern. While peripheral nerve lesions will cause this kind of interference pattern, peripheral nerve that includes cranial nerves. So reduced interference pattern comes in two flavors. One is with increased discharge rates, and this is a proof of a peripheral lesion, a loss of motor units. And a reduced interference pattern may come with this kind, and then it's characteristic of a central nervous system lesion. So reduced interference pattern is an interesting finding, but we need to know the discharge rates of the motor unit to be able to fully interpret a reduced interference pattern. When does what occur? This is the wrong line here. The increased discharge rates are found immediately upon a lesion. As I said, you need not to wait for it. And they remain with the lesion. If the recovery is full, the discharge rates return to normal. If there's a not full recovery, discharge rates may be found increased upon for the rest of the life of the patient. And keep in mind that with a total nerve lesion, there's no voluntary activity. Again, immediately upon lesion, there's no voluntary activity, though it may well make sense to do an EMG immediately upon a nerve lesion, depending on the clinical setting, when we wish to know, is the nerve damp, is it transected or not? Is there some remaining activity, or is the nerve, or is the weakness caused by CNS disorder? Then we found some motor units, but not increased discharge rates. So here's the timing of the discharge rates. We'll have another point, and then we are through with it. The usual findings, the usual suspects. Here, I talk about the polyphasic motor units. This is an interesting finding and meaningful, but it's ambiguous. Again, EMG in the muscle, all the green fibers discharge, and they will generate potentials of that shape, that kind. Now, after a lesion, repair occurs. The repair, if not all axons are damaged, is called collateral sprouting. If some axons, for instance, this green axon survives a lesion, then the nerve fiber, this one single nerve fiber, will grow sprouts to other muscle fibers that formerly belonged, for instance, to the red motor unit or to other motor units. And those sprouts will try to reach those denervated muscle fibers and will connect them to the green unit. So the green unit will grow, like settlers in the West or so. So if a muscle fiber here, those freshly re-innervated muscle fibers are indicated blue, if such a muscle fiber is reached by the green axon, those sprouts are not myelinated. So the conduction from the nerve axon to the green fibers, as it's myelinated, will take less time than the conduction time from the green fiber to the blue, to the newly reinnervated fibers. So we'll find those late components here as an indicator of reinnervation by collateral sprouting. Collateral sprouting requires that a nerve axon is still present, is lively, is intact, and is able to send those sprouts to the denervated muscle fibers. And this is the process of ongoing collateral sprouting. You see by those late components, also by increased turns, and those motor unit potentials are generally called polyphasic or desynchronous. Polyphasic is a common label for these phenomena. And polyphasicity occurs, for instance, with collateral sprouting. When collateral sprouting is successful, these nerve fibers here, formerly blue, are remyelinated. So the nervous system waits until successful reinnervation of a muscle fiber. And if one of these distal sprouts is successful, it will get its myelin sheath. And then the conduction desynchronization does not further take place. And we find now that the innervated muscle fibers are integrated into the potential. So this potential will grow as now more muscle fibers contribute to the signal, and they do it synchronously. So we have only few or none late components. Again, not many phases, but a large potential. And this is the result of successful reinnervation, particularly by collateral sprouting. So low, not increased polyphysicity, but increased motor unit potentials in late stages of reinnervation. So what do we have here? The polyphagia I told about. The collateral sprouting occurs starts some 6 weeks after the lesion. If you find polyphagia before, you may infer that there has been a lesion before the lesion under discussion or under diagnosis. Polyphagia needs some time to happen, and it takes months, let's say 6 months to 1 year, to vanish and to give place for increased motor unit potentials. And this is the residuum. The increased or the enlarged motor unit potentials will remain until death. One more word on these. What happens if no axon survives a lesion, but the nerve is repaired successfully, for instance, by surgery? Then all of the axons need to grow from the suture towards the innervated muscle. And when those axons reach the muscle, note that all axons have been dead. The first axons reaching the muscle will innervate some very few muscle fibers. And we find some very small motor units, also polyphasic as here. They're called nascent units, freshly born motor units. The further recovery happens similarly to what happens with partial axonognosis. These nascent motor units look like as in myopathy and can be found only very early upon successful reinnervation by axonal growth. Remember axonal growth, 1 millimeter per day. With cranial muscles, it's from a neurologist's point of view, it's quite rapid as it's only a few centimeters in the head. But for limb muscles, it will take months or even up to 1 or 2 years for reinnervation, which sometimes is too long. So this is the final slide here. I've reviewed the phenomena you may find, and these are, except for the differences I mentioned, they follow the same rules in cranial muscles, such as laryngeal muscles, as in limb muscles. And now I would be happy for your comments or questions. Thank you for listening.
Thank you, Wilhelm. Great contribution. I held back to my study and learned from the basics. Very didactic. Thank you. I have some questions, but first of all, we would like to give the auditory the opportunity to send questions to the chat. And during you are writing your chat questions, I want to start with the first question. Wilhelm, how do you know where the end plate region in a certain muscle is located?
Well, exactly, I don't know. Usually it's in the center of the muscle. It's easy, for instance, here, for the biceps muscle, it's right in the middle. But this is not true for all muscles, and some, especially muscles that are multi-segmentally innervated, such as anterior tibial, have several end plate zones. So from anatomy, I'm not sure where the end plate zone is. When doing EMG, it's very easy to find. Just look at the patient's face. And if it's like this, then you have found the end plate zone with the needle tip, as the end plate zone usually is painful. This is not the case. You will find these end plate spikes, very irregular activity that with a clear-cut acoustic shape. You need to study this only a few times, and you will never mistake it for pathologic spontaneous activity. It's the irregular behavior. Third, in the end plate zone, there must be there may be some kind of activity. We call it the end plate noise. That is it's like white noise, but with some bubble character. And again, you should hear this noise from demo recordings, not to mistake it for another phenomenon. And this noise is caused by some acetylcholine vesicles leaking from the end plates that are reaching the postsynaptic membrane and cause minimum changes in the voltage there, not depolarization, but minimum voltage changes that are also recorded by the needle electrode. The end plate noise. It's a rare phenomenon. More frequent, we have the pain, or we have those end plate spikes in the end plate region.
Thank you, Wilhelm. We have one question from our external faculty, from Yakubu Karagama. Yakubu, want you ask by yourself?
Yeah, I've got a couple of questions actually, because the dilemma for us, it's first of all, I'm Yakubu Karagama, laryngologist at Guy's and St. Thomas's Hospital, London. It's really the time that we have to wait before we offer surgery, because as you know, we have 3 options of surgery for these patients. We have injection, we have thyroplasty, we have reinnervation. So there are patients that they have damage from the mediastinum, in which case we know that the distance between the cranium and then the aortic arch and then back to the vocal cord is quite a longer distance. And in such case, do we expect a longer recovery, say up to 12 months or even 2 years? That's one question. And then the next question is people that have got vocal cord paralysis as a result of stroke or idiopathic, again, is longer recovery. I've had a patient that had idiopathic paralysis, and it took after 2 years before the vocal cord function returns actually. And I've had patients from stroke, and then within a few months it recovers. So I don't know if there's any guide regarding that. This will help us in determining whether we should go with surgery and what sort of surgery we should offer these patients, whether we should just do an injection and wait, or whether we should do thyroplasty, or whether we should cut the nerve and reinnervate it again.
Yeah, this is a kind of very classical question. When to decide whether to do surgery or not. I suggest, or I think you mean a paralyzed nerve, a nerve with a total damage, and you need to, or you wish to decide when to repair this totally damaged nerve, or when or if, right?
Yeah.
With a short distance between the lesion and the muscle, it's quite easy to say, well, let's just wait. It's 1 millimeter per day. So if it's 8 centimeters, it's 80 millimeters, you wait 80 days. And if there's no recovery, there won't be recovery. Give it 80, 90 days. And there will be plenty of time for the nerve to regrow after successful surgery. The question is quite difficult with muscles way apart from the system. Imagine a hypothenar, ulnar nerve. This is much more than 1 meter, and it will take, for recovery, 1 meter is 1,000 millimeters, will take 1,000 days. After 1,000 days, that is 2.5 years, the muscle is already destroyed. So you need to decide earlier as to just by wait and see. The decision whether to do a repair is critical with the distance, and it depends on the nerve or on the site of the lesion. One method could be to do, if possible, to do an ultrasound of the damaged nerve if it can be reached by ultrasound. This is typically true, except for instance, for the ulnar nerve. You can see the ulnar nerve very, very well in the ultrasound, and you look with the probe to the damaged region. If you see the nerve is transected, you know already you must do a nerve repair surgically. And as soon as you know you must repair the nerve, you must do it. Then no waiting. Very difficult question. If the lesion cannot be seen via ultrasound or high-resolution MRI, when you see that there is no action potential, that all nerve fibers are damaged, it may well be the case that the nerve is damaged. And if it's crucial, probably it makes sense to explore the damaged site and look for the nerve. And there are some centers who do intraoperative nerve conduction measurements. So you dissect, you do surgery, look for the nerve and do a nerve conduction study on the damaged nerve. And if the condition is, if the nerve conduction is totally blocked at that time, you do a nerve repair right now within the same surgery procedure. And if you see there is nerve conduction at the damaged site, you just close the wound and wait, and there's good chance that there will be a recovery. So grossly, if there's a short segment between lesion and nerve, wait and see is good. If it's a long distance to be, if there's a long distance between the lesion and the muscle, you must individually look, but the decision must be made as early as possible, as the time window is only some 12 to 18 months. After that time, the muscle fibers degenerate and reinnervation won't help.
You know, you mentioned about the regeneration of the damage to the muscle. This has been a huge controversy for us doing the laryngeal reinnervation. And we did a multi-test study not long ago, and the bar that we've set is if the injury occur within 2 years, and then we've moved it to 5 years. And the reason is because some ENT thinks that there is rarely such a thing that the muscle is completely dead or fibrous, because there is almost invariably some synkinesis, some degree of supply from other nerve that keep the muscle alive, but not sufficient to make move. And some of us have done reinnervation in patients that have had paralysis. The longest I've done is 5 years, and we found that actually the muscle tone has restored. Jean-Paul Marie said he's had it in a congenital patient with vocal paralysis, and then he reinnervated, and then he found that there's a muscle tone recurring. So this question is waiting, and whether the muscle would degenerate, again, is not very clear cut. So I don't know if you can expand on that, or is it different from the laryngeal muscle compared to the muscle in the limbs?
Well, you mentioned a phenomenon, the synkinesia, that practically does not occur in limb muscle. Of course, neurologists are very familiar with this phenomenon in the facial muscles, but we're not that familiar with laryngeal or other cranial nerve muscles. So synkinesia may lead to clinical dysfunction, although the muscle is not totally denervated. When the muscle is denervated, I think, I'm not sure of course, but I think there will be irreversible degeneration also in cranial nerve muscles, as we can see, for instance, in the facial nerve. If the facial nerve is totally damaged, the facial muscles degenerate unless they are cross-innervated from the healthy side. But if there is no reinnervation, a muscle will degenerate. The synkinesia may fake, in a way, fake denervation, as it may cause immobility of the muscle, although the muscle itself is not denervated. And of course, in this case, if the muscle is not degenerated, nerve repair could make sense, even after years. So my remarks were on totally denervated muscles. And I feel that is the same for cranial muscles as for limb muscles, but only if they are proven denervated.
Thank you, Wilhelm. I think you are right. This is only a rare condition that, but it occurs in some cases that we have really a denervation. But in the majority of the cases, we have some kind of resting innervation, of foreign innervation or synkinetic reinnervation, as we call it. And therefore, maybe late repair or late nerve transposition can help, so we think. There's another question from Kathleen from our group. Can you explain the persisting spontaneous activity? How does this work?
Well, at first, probably I started with a description. We found this persisting spontaneous activity in a patient who was referred to us during an EMG course, teaching course. And this patient, for instance, got his lesion during World War II. The course took place only a few years ago. And this patient, despite recovery, partial recovery of his lesioned ulnar nerve, this patient still had spontaneous activity in the partially recovered muscle, partial recovery. Just as an example, my personal explanation is that a muscle fiber, if denervated, starts to generate or to produce spontaneous activity, for instance, with the purpose to attract nerve fibers. It cries for help, please reinnervate me. After some time, if there's no reinnervation, this muscle fiber degenerates after some times. And we do not know when this will take place. It's kind of in radioactivity, it's an exponential decay. Several muscle fibers degenerate early, some muscle fibers degenerate later, and obviously some muscle fibers never degenerate. They never stop crying for help. And this is this persistent spontaneous activity. It's not abundant, it's few, and it gets less over the years, but it may persist up to 50 years or so after a lesion. It may.
Thank you. One question from our clinical point. We use since 2017 a surgical method where we insert an additional nerve in a, let's say, synkinetic reinnervated muscle. So we are not fine with the position of the vocal fold. We are not fine with the function of this larynx. And therefore, we think if we cut the nerve and perform a totally new reinnervation, the patient can lose some of his function, but he needs some better function. So therefore, we insert an additional nerve into this muscle. What do you think as a neurophysiologist? What will occur inside such a muscle?
Well, I have no experience, of course, with that procedure, but in theory, it should work. It requires that you dissect the supplying nerve of that muscle you wish to reinnervate. So if you insert a new nerve segment into an already innervated muscle, nothing will happen. You need to denervate muscle fibers to make them cry for help, to induce reinnervation. So cut, and was I'm understanding right, you cut the nerve that innervates the muscle today, and insert a new nerve segment or introduce a new nerve segment into that muscle. So both, in my mind, both is necessary to induce reinnervation. If you do not cut the original nerve, yes, the new nerve segment will never reach some muscle fibers for reinnervation.
So this is the theory, and what we do is that, of course, we result in a muscle lesion, and maybe we destruct some terminal endings of nerves during the insertion of the new nerve, but we still let the, let's say, old nerve in place. Mm-hmm. So from theory, it should not result in any improvement, but in reality, in younger patients, we see it works. We don't know why.
Okay. Maybe another explanation, if it works, may be that there are many muscle fibers that are still denervated when you insert the new nerve. And these muscles, the denervated muscle fibers, of course, may attract the new nerve fibers for renervation. That could work.
Thank you. That's what we think.
Okay.
Are there other questions, Gerd? Do you have a question? No. Oh, okay.
I have one comment. So even if all fibers would be renovated, some of our fibers in the face or in the larynx have more than one synapse. So perhaps not all end plates are already blocked. So the renovation could perhaps occur by the double innervation, triple innervation. So we can perhaps boost an already mostly innervated muscle.
Well, this is an issue. I'm a bit skeptic whether this frequently occurs, the double reinnervation of muscle fibers. I never found convincing evidence for this phenomenon, that there's a multiple innervation, that one muscle fiber is innervated by multiple motor neurons.
We don't need to explain it, because the other, your theory is better, that just part of the muscle is innervated and part is still denervated. And when supercharging it with another nerve, then the denervated part get innervated. So we don't need a more complicated model. Yeah. Thank you.
Well, Wilhelm, we will skip this session. You are welcome to join the course, and you are also welcome to comment and to share our discussion. And we want, after this perfect introduction to our course, we want to go to the part where we give an instruction, how we do it, how we perform laryngeal EMG, and how we interpret it. And we will start with a contribution from Berit from Vienna. So I give you the program. So this is where we are. So thank you, Wilhelm, and we